We are going live in 3, 2, 1.
Hello, everyone. A very warm welcome to our esteemed faculty and bright young minds of cardiology joining us from across the country for India Coronary Conquest 2026, a month and a half long complex PCI fiesta. Thank you for being here as we bring together real world clinical scenarios focused on complex PCIs designed specially for the early to mid career interventional cardiologist. This event is organized by AstraZeneca in collaboration with Scientimed, and we are delighted to host this national competition aimed at strengthening practical skills, clinical reasoning, and decision making in interventional cardiology. For this competition, we have received an overwhelming number of case submissions. After a meticulous review process, a technical committee has selected most challenging, insightful, and educational cases for today's semi-final session. In this competition, the category of Rising Star Cardiologist had 31 case presentations. 5 out of these 31 qualifying cardiologists were able to secure spots in today's semi-final with their case presentations. Congratulations to all the presenters. Your cases has been selected among the very best submissions across the country, and we look forward to learning from your clinical insights. Now let us hear a message from Dr. Kamal Sharma, our course principal and scientific lead.
Hello and welcome to All India Complex PCI Case Study Competition, which is being virtually run and called the India Coronary Contest, which is supported by AstraZeneca. While leading operators from across the country in this program participate, which would benefit not only to as a learning, but as well as important take-home messages about how to manage complications when they arise. As a scientific lead and principal investigator for this study, I want to invite you all to attend, learn, and contribute to this science with eminent faculty across the country once in every week, as the timelines would be discussed with you, with 90 minutes of which would be looking at 5 fantastic cases across 10 episodes, and then to look at the finals where you would be judging the best case contributed into the platform. Looking forward to have you with the scientific learning across the board. Stay connected and watch out for the episodes across. Take care. Bye bye.
Thank you, Dr. Sharma. Now we'll move on to the introduction of our course principals for today's session. Please join me in welcoming our distinguished course principals. We are honored to have with us Dr. Prakash Kumar Hazra and Dr. Y. Vijay Chandra Reddy. I'll give a short introduction for the speakers, and it is my privilege to introduce Dr. Prakash Kumar Hazra. He is the head Department of Cardiology, Manipal Hospitals, Dhakuria, Kolkata. Dr. Hazra is a senior interventional cardiologist with extensive experience in advanced cardiac care. He has performed more than 10,000 angioplasties and over 20,000 angiographies. He is a pioneer in multiple first of its kind cardiac interventions in Eastern India. He is an expert in TAVI, complex coronary interventions, structural heart diseases, and device therapies. He is an international faculty at leading conferences including TCT, TCTAP, Cardiology Society of India, and Singapore Live. He is a recognized proctor for advanced technologies including leadless pacemakers and LAA closure devices. He is also actively involved in teaching, training, and mentoring cardiologists across India. He has contributed significantly to the clinical research, innovation, and adoption of therapies. We are delighted to have him with us today. Welcome, Dr. Prakash Kumar Hazra.
Thank you.
Welcome. Joining Dr. Hazra, we have Dr. Y. Vijay Chandra Reddy. It is my privilege to introduce you, Doctor, who is a consultant interventional cardiologist, Apollo Hospitals, Chennai. Dr. Reddy has extensive experience in coronary interventions, including primary PCI, CHIP PCI, CTOs, bifurcations, LM, and complex cases. He has expertise in advanced technologies such as robotic angioplasty, ROTA, IVL, and laser interventions. He is highly experienced in aortic interventions and complex vascular procedures. He's a pioneer in structural heart interventions and he has vast experience in cardiac device therapies. He's a recipient of multiple gold medals, awards, recognitions, including Best Interventional Cardiologist. Welcome, Dr. Reddy. So, before we begin with our expert talks, I'll quickly run through the agenda for today. First, we will be having expert talks by our both course principals for 5 minutes each in today's session. After that, we will move on to the five complex PCI presentations which are scheduled for today in the semi-final session. Each presenter will have 10 minutes to present their case, followed by a 3 minutes Q&A session. So, with that, let us today begin with our first experts talk. I would like to invite Dr. Prakash Kumar Hazra to deliver his talk on the topic Enabling GDMT in HF with Novel Potassium Binder SZC. Over to you, Dr. Hazra.
Yeah. Can you share the slides, or
The
there is
presentation.
no option
Okay.
from here? Yeah.
Can you share the slide for Dr. Hazra?
Yes, a minute.
Okay.
So can you see slides? I've done that. Can you see it? Hello?
Yes, sir, we can see.
All right. All right. So friends and Dr. Reddy, good evening. So very brief introductions of Lokelma in India has already been done. But briefly speaking about the utility, it's a tremendous drug for patients who are suffering from chronic heart failure, chronic kidney disease, and they need the best of therapy, that is ACE inhibitions, diabetic nephropathy, finerenone, different kinds of MRA, steroidal, non-steroidal, and there is a price issue about the aldactone versus finerenone. So most of our Indian patients, they receive aldactone, which is notorious for causing hyperkalemia, especially in the setting of poor fabulous foundational drugs like ACE inhibitor, RAS, and ARNI. And if they are not on diet control in the background of CKDs, if they are taking a lot of DASH diet, which is very rich in fruits and vegetables. So RAS inhibitions is definitely one of the best therapy in the armamentarium of heart failure and chronic kidney disease. In spite of using dapagliflozins, empagliflozins, the incidence of hyperkalemia is incremental because many times the creatinine goes down. GFR goes down, creatinine goes up. So most frequently seen with CKD. So dialysis is a solution, but dialysis takes time. It is costly, invasive procedure. It is welcome thing if it is tolerable without any ECG changes, chronic hyperkalemia in the setting of dialysis. But if it comes all of a sudden without any dialysis, then it is dangerous, can cause sudden cardiac death. So mild, moderate, severe hyperkalemia can lead to discontinuation of GDMT as a kind of stigma. That means once you are hyperkalemic, you are barred from one drug, MRA, definitely most of the time. Maybe second drug is also barred from your list of heart failure, that is RAS inhibitions. Maybe in the future we will have aldosterone synthase inhibitor for hypertension and other things. You'll face the same difficulty or same kind of problem of hyperkalemia. So resistant hypertension, give aldosterone synthase inhibitors or aldactone can lead to hyperkalemia. So the missing piece to control hyperkalemia, we had a lot of drugs in the past, but these drugs had a lot of side effects. So ZC crystal, zirconium, is exactly 3 atomic size of potassium, and it exchanges hydrogen for sodium and potassium, highly selective for potassium binding site, width, and potassium ionic diameter. So it is insoluble, highly stable, and does not expand in water. So it does not cause too much of side effects like those chelating agents. So this is the trial harmonized plus extension mean serum potassium levels across correction, maintenance, and extension phases. 88% patients receiving this drug, they maintain a good potassium level all the time. So treat them with high dose initially and maintain them. And the beauty of this zirconium or your localma, if you continue this drug, do not hypokalemia. Patients with heart failure who are treated with zirconium for hyperkalemia are more likely to maintain the RAS therapy for better period of time. So zirconium is very essential to continue, and you don't have to reduce the dose. The dose escalation is possible. Same dose is maintainable in most of the patients if they receive this drug, but it needs continuous monitoring and dietary restrictions. So avoid unnecessary drugs if it is not essential, and choose zirconium to treat hyperkalemia in the ICU, beyond ICU. With that, I'd like to thank for your kind attentions. May I hand over the session to the organizer. Thank you very much.
Thank you, Dr. Hazra, for that informative start and setting the tone for today's session. I would like to next invite Dr. Y. Vijay Chandra Reddy to deliver his talk on reversing structural damage with dapagliflozin. Over to you, Dr. Reddy.
Thank you. Thank you, Akansha. Thank you, Azra. So mine is a small talk on reversing structural damage with dapagliflozin in the primary setting of ACS and STEMI. So we all know that in the 4 pillars of heart failure, we have SGLT2 inhibitors, RNA beta blockers, and MRA. And of course, the 5th pillar of vericiguat. Predominantly, SGLT2 inhibitors we know are useful in both HFrEF and HFpEF as well. But today I'll be focusing on the role of SGLT2 inhibitors in heart failure in acute MI scenario. We know that in acute MI, the important prognostic factor is the LV dysfunction. Myocardial damage and heart failure is seen in almost 37% of people during the index hospitalization of MI, 2/3 by 1 year, and more than 70% at some point of time in the 5 years. So it makes sense to attend to this problem because LV dysfunction leading to heart failure itself increases the cardiovascular death and mortality by 3 to 4 times normal. So when you use dapagliflozin in this setting, definitely there is a reduction of MACE, 10% of relative risk reduction in terms of cardiovascular death, MI stroke. Independently, cardiovascular death and all-cause death also is reduced 14%. This is a significant number. 1.5% absolute risk reduction in the acute MI setting is a very important one. Hospitalization for heart failure is one of the important MACE endpoints nowadays we have recognized. And in that also, there is a significant 25 to 30% relative risk reduction. And this effect is consistent across the full range of LV ejection fraction. So you find an acute MI, and if there is an LV dysfunction-related heart failure at different ranges of LVEF, it translates into very good benefits. In the DAPA-MODA study, there is another study to look at the cardiac remodeling in chronic heart failure. When you start dapagliflozin, cardiac remodeling is achieved in terms of structural changes like LV mass index is reduced, LA volume index is also reduced. So, and also the biochemical surrogate of heart failure, the NT-proBNP is also reduced. So we have the reason for the MACE reduction and the translation of benefits is because of structurally remodeling of the heart in a favorable way, and also the surrogate of biomarkers is improving. same thing, you can see here the NT-proBNP levels are improved. And what about SGLT2 post-ACS? The same issue. When you see post-ACS as well, there is an ejection fraction improvement and end-diastolic dimension reduction. That means structurally the heart is getting better, adverse remodeling is being reversed, and ejection fraction is improving and translating into NT-proBNP reduction as well. So acute MI also, dapagliflozin has a role. There were some studies where there was some opposite effects, like the impact with the empagliflozin in MI did not show much changes, but at least if you see the dapagliflozin trials, there are tremendous advantages in this scenario. And in PCI patients, again, there was one small paper from Lee Yu et al. 70 patients of ACS PCI in diabetic patients. If you use dapagliflozin, again, not only glycemic improvement, but also ejection fraction improvement, and also the myocardial perfusion had improved as measured by the TIMI frame count. So there is a role for ACS patients also. You can start dapagliflozin as soon as you find MI patients. In diabetics, of course, it has to be started off straight away. In a non-diabetics also, as we have shown, it can be started within 3 days if there is LV dysfunction. Thank you.
Thank you, Dr. Reddy. After these enriching talks from our expert faculty, we now move on to the presentations. Before we begin the case presentations, a quick reminder for all our participants. Each presenter will have exactly 10 minutes to present their case, followed by a 3-minute Q&A session. As this is a time-regulated session, we request all the speakers to kindly adhere to the allotted time. I'll provide a gentle reminder when only 1 minute is remaining. And now, without further ado, let us begin the case presentations. Our first case presentation today is by Dr. Vijayan Ganeshan. He is presenting his case on My Worst Nightmare in the Cath Lab. Dr. Vijayan, the stage is yours.
Yeah, I'll just share my screen.
Right.
Can you see my slides?
Um,
Not it.
yeah, they are visible now.
Yeah.
They're visible now?
Yes.
Yes.
Am I audible, sir?
Yes, you can switch to presentation mode.
Is it fine now?
Yes, yes. Now it is okay.
Yeah. Good evening, respected chair, and good evening, everyone. My worst nightmare in the cath lab. The story of a 56 years old gentleman, a type 2 diabetes mellitus hyperlipidemia, admitted with chest pain in the nearby hospital, diagnosed to have ACS, NSTMA, normal LV systolic function. An angiogram done in an outside hospital showed a single vessel disease. He underwent PCI2 OM3 at 8 p.m. in the night. These were the angiogram shots taken from other hospital where RCA was codominant and circumflex was codominant. OM3 had a tight 99% lesion, distally TIMI1 flow, and in LAD in epicranial view.
Did you
Hello.
lose?
I think there's some technical issue with Dr. Ganeshan. Can you confirm, like we still have Dr. Ganeshan or he has
Yeah,
left?
I'm doing it. I'm doing it.
Okay.
Dr. Vijayan is joining.
Okay.
Can you hear me,
Thank you.
sir?
Yes, yes,
Extremely
you're
sorry
audible.
for that. There's a technical glitch there. So can you see my slides?
Yeah, they are visible.
They are visible, right? Sorry for the disturbance. So he underwent PTCA from the nearby hospital where it was initially the operator dilated the lesion with a 2 mm balloon, and then he put a 2.25 into 18 mm drug-eluting stent, and it was a science stent, science expedition. After deployment, there was a small amount of under expansion middle of part of the stent. So till this time, it was very clear, and suddenly the patient developed severe chest pain 30 minutes after angioplasty. The cause of it was exactly not known. And then he underwent a check angiogram in the same hospital. There were only 2 angiogram shots taken. With that, it's very clear that there was some hazy lesion that's present in the distal LMCA, proximal circumflex, and proximal LAD. And he was being urgently referred to our hospital for further management. The treating cardiologist informed me over phone, and it was a difficult guide cannulation. And he thought it was an LMCA thrombus. And then he started the patient on injection tirofiban. And the cause for it is not clearly mentioned. It was not known. And he's referred to our hospital. At 12 o'clock in the midnight, the patient was landed in our hospital with severe chest pain at midnight, 12 o'clock. And ECG was taken short, normal sinus rhythm, diffuse ST depression in infralateral leads with ST elevation in AVR more than V1. Taken up for an immediate angiogram, which shows this. An extensive LMCA dissection right from the ostium extending into the circumflex and into the LAD. I was very careful not to take too many views, just one caudal and just one cranial to know the distal extension. Just used some 6 ml of contrast. So there's just TME1 flow both in LAD and circumflex. I was not very sure how the patient survived for 4 hours to come to our hospital, to be frank, because there's no collateral supply from the right side also. It was just a small co-dominant vessel. Suddenly the picture changed. The patient developed sudden cardiac arrest with ventricular tachycardia. We revived immediately with 2 cycles of GPR with 200 joules DC shock. Tirofiban infusion was immediately stopped in view of dissection. I also had very difficult time cannulating the LMCA. Initially, since it was an LMCA dissection, I initially tried with JL 3.5. I was very particular to keep the guide outside the ostium and to take some check injections. I couldn't do that. With JL4, I couldn't cannulate. And finally, I could even cannulate with the EBU 3.5, but then I was very careful not to deeply engage into the LMCA because it was already a dissected vessel. I kept it just outside the ostium. I initially used a floppy wire to wire, that is cyan blue, couldn't wire, run through, I couldn't. And fine, that was in the middle of the night, I was single operator. And initially, then took the stiffer wire like filter XT and fine cross micro catheter. The wire kept on going to the large false lumen, both in LAD and circumflex. You can clearly see over here. That's a small true lumen. This is the false lumen. You can clearly see the wire kept on going to the false lumen. I couldn't wire the true lumen. Then I just took some time, came back to the console and paused it. And the cranial view, it is so clear that the true lumen is very small and is just 1 millimeter. Since the false lumen is very huge, the wire kept on going to the false lumen. What I did was I just gave a good secondary curve, the tip of the stiffer, that is fielder XT wire, and then took no chance. And immediately when the moment I wired circumflex, just with wiring alone, there's a TME3 flow which has happened. And then again, I could wire both LAD with the same fielder XT wire. So I took no time just to dilate with 2 mm balloon, both in LAD and circumflex. Now there was TME3 flow. So now what next? The hemodynamics improved. The patient BP rose to 130/70. So obviously, minded it's a dominant circumflex. We cannot forego circumflex. It's going to be a 2-stent strategy. And if it is a 2-stent strategy, what? Is it a mini crush, a kilo, a DK crush, or else a tap tending to be most simple? So I chose DK crush for following reasons. It's obviously an LMCA bifurcation lesion. Patient at that point of time had stable hemodynamics with TIMI3 flow both in LAD and circumflex. It was dominant circumflex. The wire in the main vessel is not at all removed in a DK crush, but it was removed if you chose kilo. Intracoronary imaging was not done because of financial constraints and it was an emergency procedure. I went ahead and then placed a 3.5 to 15 mm balloon in the LAD and 3.5 to 18 mm DES in circumflex. I first deployed the circumflex stent, used the 3.5 mm to crush the proximal part of the circumflex stent, rewired through the proximal stent struts, initially opened with a 1.5 balloon, and then opened it with a 2 mm balloon, and then post dilated with 3 mm balloon. So, and then did the first kiss with 3.5 mm in both the sides, LAD and in circumflex. So you can clearly see there's a TIMI3 flow, circumflex is completely taken care of. You can clearly see there's an extension of the dissection flap from the LMC ostium into the LAD is still persisting. Did the distal LAD stenting with 3 into 26 mm drug-eluting stent, and then placed a proximal, that is right from the LMC ostium to overlap with the previous LAD stent. I was very particular to keep 1 to 2 mm outside the LMC ostium to cover up the LMC ostium, remove the circumflex wire, and then again rewired the circumflex through the proximal stent struts. And even after doing that, you can then I opened the struts with a 1.5 balloon, then with 2 mm balloon, and did the second case with 3.5 mm in each, and then did a LMCA pot first with 4 into 6 mm balloon pot PTCA, and still there is a dissection flap which is still persisting both in iliocranial and epicranial views. Didn't take a chance, took a 5 into 6 mm pot PTCA balloon, did the second pot with 5 mm balloon. So you can clearly see those are the final shots. It was very really gratifying. TIMI3 flow both in LAD and circumflex. So again in LA caudal, I just placed this guide just outside the ostium and then took the views. So the take home message here is always try to avoid deep engagement of the guide catheter. Probably since I presume that the operator had a difficult guide cannulation, would have cannulated the guide more deeper, that would have dissected the LMC ostium, extended into both LAD and circumflex. Whenever you find LMC dissection, disengage the guide catheter, take gentle sinus angiogram to know the further extensions and tell less number of shots. That's very important. If at all ostial LMC is involved, try to use Judkins catheter. In my case, I couldn't do that, but that is the reason why I took ABU. Try to limit the angiogram shots. The most important key for the success is identify the true lumen and wire it swiftly. If at all the ostium is involved, obviously you have to seal the entry point to prevent the progression of the dissection distally. Thank you for your patient hearing.
Thank you, Dr.
Yeah.
Ganesh.
What-
We can begin with
Yeah,
the
wonderful.
Q&A session.
Yeah,
Experts.
wonderful case. I think the most interesting part on education will be how to enter the true lumen.
Yes,
So if you face this problem again, we'll do the same thing, or you will learn from this case, or you will take some help of the newer technology. Is there any other way of doing this case to enter the true lumen?
Yes, sir.
Any other device, microcatheter?
Yeah, obviously. Yeah, one thing is you can use an imaging with the whatever level of the wire is like in CTO cases and all, to know where your wire position is. You can use an IVS guided positioning of the true lumen or false lumen. That way you can do. And second thing is we do have dual lumen microcatheter these days. If at all your wire cannot pass through the true lumen with a distal cap, with a dual lumen microcatheter, you can slightly try to place it just at the bifurcation of the distal LMCA and try to wire in one of the true lumens of the LAD or circumflex, because I had difficulty in wiring both LAD and circumflex. Since it was middle of day, I was a single operator. I was frantically looking to wire either of the vessels. Since I couldn't do it actually initially, because I showed it clearly that the true lumen is very, very small. Because of the financial constraints, initial he was admitted in the government hospital, then he came to the private. So because of the financial constraints, and I don't want to waste bit time also actually with an imaging, that's the reason why I couldn't go ahead with the imaging, sir, actually.
Yeah, I know imaging is the way to go, because if you put a stent in the false lumen and your
Yeah, it is
stent
still
is
closed.
across circumflex, you'll never be able to go into
Wire.
the circumflex because it is closed. So micro catheter, double lumen, maybe outside the ostium, entering with a larger loop of a different catheters, or keep the wire in the false lumen, take another wire with a larger, almost 360,
Yeah.
almost 180-degree loop, soft catheters. Even, sometimes the new catheter, New
Yes.
Year, Suho, such a delicate wire. It goes, with the flow, even in a small lumen. But again, it is always a chance rather than is a routine thing to enter into this very chinky true lumen because it is compressed by the hematoma. Or you can penetrate the false lumen with a Gaia 3 wire through the
Yeah.
micro catheters. So true to false, false to true is the way to go. So you will enter from the false to true, and always you can check on imaging if it is available. And the next is you keep a small balloon, uninflated balloon, 1.5 millimeter balloon, that will prohibit the entry of the second wire into the false lumen, and perhaps that may help. So the luck favors the brave. The patient saved, and you saved a important life. That's very important. Thank you.
Thanks a lot for your valuable insights, sir. Thank you.
Nice
I will-
case. Good
Yes,
save
sir.
again. Yeah. Is there a time
Thank you.
left, Akansha? Or you'll be keeping the time
Yeah,
there?
you can continue.
Yeah, it's a good case. For the audience, good. If possible, use a JL. Of course, we had to use this. The guide catheter was probably the reason for the
Exactly, sir.
dissection
That's
because
it.
we could see when you were tackling it in the superior rim in the RAO caudal views, the long linear dissection was there, which occluded it. Many a time, the best way is the catheter. You have to withdraw the catheter a little bit up back into the aorta so that the lumen of the catheter is pointing towards the enter the lower part of the LMCA. It will enter easily into the true lumen. And the best thing is, as you have shown, take time, take 2 shots in orthogonal views, minimum dye, don't inject too much and send it into the intramural hematoma and see it, study it, and then go with a good secondary curve. That's the important thing. These are the cases where you have to take a good secondary curve. It usually enters, and then you need not go for specialized wires. Even a simple BMW would work. In fact, a BMW would be superior for one reason being that it won't track into the false lumen so easily like with their filters. So of course, with expert hands, you can use a fielder as well, because if you have a good knowledge about the tactile field, Dr. Vijayan did it excellently with 2 wires. And then the way to go is that. But in the last part, only one thing I would have said differently is you don't have to worry about the false lumen visualization after stenting doing every job. Good job, because these are not covered stents. You will still get some staining of the even after the angioplasty. So you need not hunt it with a 5 mm and all that. So wonderful. And again, for the most of the times, these guide dissections, the retrograde dissection back into the aorta is extremely unlikely. You can position the stent at the true ostium, or in fact, you can save 1 or 2 mm of ostium so that you won't have the problems of stent deformations and future entries and all that will be easier. But wonderful save. I know it's how difficult it is to tackle these cases and save in the middle of the night, single-handed. Excellent.
Thank you, sir. Thanks a lot for your valuable insights.
Thank you, doctors, for the discussion. Next, we have Dr. Dinesh Kumar with us presenting his case titled Rotational Arthrectomy in ACS. Over to you, Dr. Dinesh.
Good evening, sir. Good evening, one and all. I'll just share my
Good evening,
screen.
Dr. Dinesh. I would request you to be a bit louder. We are very minimally able to hear you. You can flash your screen.
Good evening, sir. Is my screen visible, sir?
Yeah, it's visible.
Good evening once again. Our patient was an 82-year-old gentleman, a diabetic and COPD. He had angina at rest for 2 days, and he was diagnosed with ACS non-ST elevation MI with regional wall motion abnormality in the radial territory with EF around 45-50%. Since he had angina, we took him for an angiogram early, and the angiogram shows left dominant system with critical stenosis in the proximal and mid LAD and significant stenosis in the obtuse marginal branches as well. And in the caudal view, we are able to see the culprit lesion in the proximal LAD and a calcified lesion in the mid LAD. RC was non-dominant. Since he was elderly, 82-year-old with severe COPD, he was considered very high risk for CABG and he was planned for PCI2 LAD. And we had planned to take an IVS to decide on the calcium, and calcium modification will be based on the IVS. So both the lesions were wired, LAD and obtuse marginal branches were wired. And unfortunately, the lesion in the proximal LAD IVS was unable to cross. And so we had two options, either to go with balloon dilatation serially followed by cutting balloon or intravascular lithotripsy, or go ahead with rotational atherectomy in case the calcium was severe. This is where the fluoroscopic calcium severity came in handy, and we were able to see fluoroscopic opacities even without cardiac motion on both sides of the vessels, at least on one location, and length of more than 15 millimeter, and we were able to see in all the four views. So we thought the calcium was significant, and we planned to go ahead with rotational atherectomy. Since rotational atherectomy has a risk of slow flow, especially in acute coronary syndrome, we plan to take in an IABP before starting rotational atherectomy. So a rota floppy wire was used and it was exchanged over the microcatheter. And we started rotational atherectomy with the 1.25 millimeter burr at a speed of 1,60,000 rotations per minute. We were able to ablate the lesion in the proximal LAD. But once the catheter burr was in the mid LAD, it got entrapped in the lesion in the calcium in the mid LAD. With deep intubation of the guide catheter with gentle traction and a bit of forward motion with a higher speed, we try to gently retrieve the burr. Fortunately, we were able to retrieve the burr with a simple maneuver. So this kind of retrieval will be followed usually sometimes dissections or perforation in the proximal vessel. So when we just gave a check shoot in the left main, and we were able to see that the entire system, the guide catheter, the guide wire, and the burr had dislodged from the coronaries, and with some difficulty, we had to wire with the rota wire. Fortunately, we were able to cross the lesion in the LAD again. After getting system in place, we started rotablation again, and this time we took the same burr with the speed to 1.5 lakhs rotations per minute, and the proximal and mid LAD we were able to rotablate with a gentle taking motion. Post rotablation, angiogram showed TIMI3 flow with no slow limiting dissections or perforations in the proximal vessel. In the caudal view, we were able to see two 90-degree tortuosities, which are very close to each other, with significant calcium. This could be the reason why our burr got entrapped in that location. Since we had not seen this carefully and we are ablating only in the cranial view, we missed out on that. Maybe if we had checked this, we would have been a little bit more gentle and more careful at this segment. And post rotablation, we did the IVS, and IVS in the distal LAD showed a fibrocalcific lesion with a calcium mark less than 180 degree. And in the lesion in the mid LAD showed significant calcium, here 270-degree calcium, thick calcium, and followed by approximately 360-degree calcium. And we are able to see multiple calcium breaks following rotablation. And this is a reverberation artifact post rotablation. And the lesion in the ostium, near the ostium, the proximal LAD, was a fibrotic lesion with more lipid core, which could be the culprit. So we followed the rotablation with a cutting balloon angioplasty along the LAD, throughout the LAD. And I was following cutting balloon angioplasty, showed significant calcium breaks in the distal LAD. And even in the mid LAD, where there was 360-degree calcium, we were able to see multiple calcium breaks involving all the quadrants. There were breaks in all the quadrants. And the lesion in the proximal LAD was also well prepared with the cutting balloon. So we had to use two stents and 2.5 millimeter stent in the mid LAD and 3 millimeter stent in the ostium to mid LAD. And post stent deployment was good, and we did post dilatation with a 3.25 non-compliant balloon. So final IVS showed the distal, there was no distal edge dissection or malapposition or geographical miss. The mid part where there was significant calcium, the minimal stent area, we are able to see concentric expansion with minimal stent area of 6.8, and the proximal LAD, the stent area was 8.2, and stent extending up to the ostium. Final angiogram showed TME3 flow with no obvious complications, all branches flowing well. There was diffuse disease in the distal LAD that was left for medical management. So from this case, what we had learned was rotational atherectomy is still possible in patients with ACS, but there are few things to be kept in mind. One, there should be no evidence of thrombus, no obvious dissections, and no significant tortuosities. In our case, we had a burr entrapment. The risk of burr entrapment is more common in tortuous vessels when we use a 1.25 millimeter burr and poor technique and high rotation speeds of more than 180,000 rotations per minute. In our case, we had tortuosity. We had used a 1.25 millimeter burr. Since the 1.25 millimeter burr, the shape is different, so more bullet shape rather than cylindrical. The risk of burr entrapment is more. And technique also could have been a factor in our case, where a more gentle pecking motion would have avoided this complication. After retrieval of the entrapped burr, there could be excess loop or tension on the wire or non-coaxiality. This could lead to uncontrolled jerky movement of the guide, catheter, and burr, would have caused dissection or acute vessel closure or loss of coronary wire access, as it happened in our scenario. So this could be prevented by eliminating the accumulated tension during each and every step and coaxial alignment of the guide wire and the rotablation bulb. Thank you, sir.
Thank you, Dr. Dinesh. Experts, we can initiate the Q&A session.
Ready.
Yeah. See, a good case. I just missed it. Was the initial balloon crossability tested for a non-compliant balloon?
No, sir. We didn't do so.
No. Okay.
Why I thought was once if we dilate the lesion, there could be dissection, so rotablation will not be possible. So
You did
I
the
didn't do
IVS
the
and
test.
then
Only
CDL
IVS
went there,
catheter
is
we
it?
tried.
Oh, usually because you didn't have an IVL there, is it? You had an IVL with you that
No,
day? No.
IVL was
Available?
I didn't.
Oh.
No, sir.
No,
It
no,
wasn't available, sir.
not available. But usually the best, safest way for tackling calcific lesions in acute coronary syndrome, MI, ACS, STEMI, is an IVL. In fact, I think it's a good point. You've done the case extremely well with the rota and escaped even with the most notorious complication of burr entrapment. Very, very lucky, as well as probably good technique also. And a heart of steel.
We were lucky, sir. We were lucky, sir.
Heart of steel. But normally what we tell is keep IVL. Nowadays, IVL is mandatory in all labs because primary PCI has become the norm. And you are getting more and more elderly patients in 8th and 9th decades of their life. Lots of calcium will be there. And it is not at all a big issue. Once IVL is there, it is very safe. You can crack the entire lesion. And then it's extremely useful in this scenario. Only in the rarest of the rare cases where you cannot pass the balloon. Now, balloon uncrossable, yes, the rota can be done. It is safe if you do in a nice way. Don't go for very high speeds to reduce no flow, slow flow. One thing is go for slow speeds. If possible, always use a 1.5 bar. 1.25 is a bit risky. And you are rightly pointed out, excellent point, that there was a 90 degrees angulation after the diagonal origin. And again, it's not only entrapment. Sometimes it can cause vessel perforation, rupture also. Again, you have been blessed there. You got away with a good result without those sinister extra complications. Excellent.
Yes, sir. We are fortunate in 2 or 3 occasions in this case.
And one more thing is when you pass a balloon, if the IVUS is also not there, initially you pass a balloon and before inflating the balloon, you can do a stent boost. We are calling it balloon boost. Without then you can see the calcium easily on both sides in orthogonal views. You take it, you inflate the balloon and see for the lesion crackability. That time again you do the stent boost. So with the inflated balloon, you can see again the dynamics of the calcium. So this all helps you when you don't have imaging in an acute MI setting. Excellent case, yeah. Prakash.
Thank you, sir. Thank you very much, sir.
Yeah, I think nicely done, nicely executed. IVL definitely should be handy in these cases. Opium balloon, IVL, it should be made available in most of the cath labs because nowadays the price has come down. Whether it is Indian and non-Indian, Indian IVL are pretty good and they are very effective and comes with much lower budget. So IVL should be, I know, and you have done the case in the right fashion. But as Dr. Reddy has mentioned, IVL also
Yes,
should
sir.
be one of the choice. Good case.
Yes, sir. Thank you, sir. Thank you very much.
Thank you, doctors, for your comments. Next, we have our presenter as Dr. Abhijyoti Biswas. His case is titled Triple Calcium Modification for Heavy Calcified LMCA LED lesion in an octogenarian rota cutting balloon and IVL used in synergy.
I'll just need some guidance regarding this. I'm not able to
So below
share
you
my
have a share
screen.
option.
Yeah,
From
I
there you can,
clicked on it, but there content
once you
only, I think.
once you click Dr. Biswas, it will show to share Chrome tab, window or entire screen. So you can select the needful.
Yeah. Is it visible now? My
Yes,
slide
it's
is it?
visible. Yeah.
Okay. So, okay. So, good evening, everyone. I am Dr. Abhijyoti Biswas presenting this case which of triple calcium modification for heavily calcified LMCA LAD lesion in an octogenarian. So our case is our patient is a 81-year-old female with who is a known case of diabetic hypertensive and has a history of acute onset chest pain which started 4 days back. At presentation, her troponins were elevated. Creatinine was also elevated, which, however, stabilized during the hospital stay. And HbA1c was 6.6, LDLs were 61. An echocardiography showed fair LV function. There was no evidence of any RWMA, but patient had grade 2 diastolic dysfunction. So we diagnosed her as a case of NSTEMI, ACS NSTEMI, fair LV function with grade 2 diastolic dysfunction. And so we take her up for angiogram. Now, the angiogram clearly showed significant calcified multifocal lesions involving all three coronaries. Particularly, if we look into the LAD, there are multiple calcified tandem lesion with significant stenosis, and the RCA is also RCA is a calcified CTO. So based on that, what we initially planned was that we will wire the LAD and we'll do an IVUS image, IVUS, and based on our IVUS findings, we will decide our further plan. However, we found it difficult to deliver the IVUS catheter across the lesion or even dilate it with a small sized balloon. So we had to go for upfront rota ablation. So we took a 1.5 mm burr, and as we proceeded, we realized that there were multifocal lesions. As you can see, these are some areas of which only gave way after multiple pecking of the lesions. And down again over here, we see that there was another significant tight calcified lesion which broke away only after multiple runs of rota. This is our final angiogram after rota ablation, which shows good flow. There was no major dissection, flow limiting dissection, although during the procedure of rota ablation, patient had developed slow flows, which were tackled with intracoronary vasodilators during the procedure. So after this, what we decided was now it was time for NC dilatation and we will then do some imaging. Unfortunately, as we proceed, we find that our NC balloons started slipping, that which suggested unyielded calcium in the vessel, significant unyielded calcium. So next in order, we went for cutting balloon dilatation. We took a 2.510 cutting balloon dilatation, and as you can see that the balloon was pretty much eccentrically inflated. There was no uniform inflation, but it did not slip definitely. And after creating some micro incisions, this time we were ready for IVUS. So I'll just skip through I'll just focus on the important parts of IVUS. So the initial part we see there's some area with a relatively healthy area in the lower part of the vessel, but as we proceed proximally, we see there are areas of significant calcium, and particularly in the proximal LAD, you can see that these are those areas where there is almost 360-degree calcium. We can see, and these significant plates of calcium were extending proximally till entire proximal up to ostial LAD, and also extending partly into LMCA. So there was a significant heavily calcified lesion in LAD. There were still 360-degree plates of calcium, which had not yielded even after rota and cutting balloon. So this is our summary of our IVUS images. We have a distal reference of around 2.5 to 2.75. Somewhere in mid LAD, the areas are around 3.5, and this is in the proximal LAD. We have this significant 360-degree calcium with area of only 4.3 and significant plaque burden. Proximal LAD has a reference diameter of around 3.5, and this is our LMCA with some mild plaques and with a reference diameter of 4.5. So having acquired the necessary information from IVUS, we decide that an IVL is indispensable in this case. So we take up an IVL balloon, 2.5 IVL balloon, and we deliver 120 pulses of IVL across all the calcified lesions in LAD. And interestingly, after this IVL, we find our IVUS images showing newer cracks in our thick plates of calcium, ensuring that further that our vessel is now prepared for stenting. So we initially take a 2.75 38 stent for distal LAD, and post dilated it with 2.75 and 3 NC balloons. Then from another stent of 3.5 38 was put from proximal from LMCA to LAD, and we did a pot with 4.58 balloon, and across the circumflex we gave a dilatation of with 3.512 balloon. And here you can see this is our tightest portion, which at this point is showing good balloon expansion, which we had also confirmed in orthogonal views. So this is our final angiogram, and this is our final IVUS image. In our IVUS, I'll just skip through this part. We can see distally it has landed pretty safely in a relatively healthy part of the vessel with no any edge dissection. And as we see the rest of the vessel, we see that it has significantly there's good expansion. There is no malapposition anywhere, and this is the part where in proximal LAD, which we had significant calcium in, and now we can see that it has expanded pretty well after all the calcium modification we have used. And this is the LMCA, which showed good expansion. So to sum up, this is our final IVUS image. Now proximal, now distal LAD we achieved area of 5.6 in proximal LAD, and 8.6 area was achieved, and in LMCA 14 area was achieved. Now if you see in the longitudinal view, this is the point which is the tightest, the tightest point even after stenting, and the MSA at this point was somewhat around 5, which we found acceptable at this stage. So to sum up, I'll just say that no significant calcium modification technique is universally effective. Rotational atherectomy still remains a powerful initial tool to create a pilot lumen and modify the superficial calcium, which facilitates subsequent balloon-based therapies. Cutting balloon, these are valuable for treating balloon slippage or focal resistant segments after rota ablation, and it provides controlled plaque incision and controlled dissection of the plaque. IVL, it is very much effective if there is almost 270 or 360-degree calcium mark, and also it has a role in fracturing the deeper circumferential calcium, thereby complementing the effect of rota ablation and cutting balloon. IVUS or any form of intravascular imaging is indispensable for tackling such cases, be it the information that we get about calcium morphology. It helps us in selecting our tools and also in optimizing our stent expansion. So last but not the least, I would say that sequential and synergistic use of different calcium modification tools like rota, cutting balloon, and IVL can transform an undilatable, severely calcified lesion into a stentable one with optimal expansion and favorable IVS parameters. Thank you.
Thank you, Dr. Vishwas. Experts, we can initiate the session for discussion.
Good case again, which was the usual real calcific challenges. My one question for you will be, why not skip the cutting balloon part and after rota straight go for the IVL, because it will modify the calcium in a better way. And you would do, I hope it was a C2 plus catheter
Yeah,
with
yeah,
120
yeah.
pulses. Yeah, 120 pulses.
Actually, what we had decided was we primarily decided to do an imaging to decide our cutting our calcium modification tool. But unfortunately, the cutting balloon the IVUS didn't go initially. So after that,
Yeah,
we
rota was
decided to
mandatory, I agree.
yeah
But
rota we had done.
after the rota, straight IVL rather than using the cutting balloon.
Yeah, so IVL was an option, but again, the cost of therapy would have say we just tried to spare the cost of therapy if it was
You wanted to
possible.
avoid IVL and see whether it will
Yeah,
work.
if
Okay.
it could be
Okay.
done.
Okay.
So we tried it with cutting balloon, but obviously
Yeah,
the images suggested
correct.
that the calcium mark was
See,
significant, so we had to
this type
proceed
of
with rotavital.
calcium, ideally, IVL is mandatory. And then still, you see, there was some lesion in the 1 point you showed, 5 point. There, if you had some pulses left, you could still use it post stenting also. So,
Yeah,
though it might cause some damage to the polymer, you could use
yeah.
it to
Actually,
modify the calcium behind the stent. Yeah,
unfortunately, we had already delivered all our
exhausted
120
all the
pulses,
pulses.
so
Okay.
we didn't have any left with.
So these are the usual challenges, good results. Excellent.
Thank you, sir. Thank you so much, sir.
Yeah, I think a nice case. Do you keep the high pressure balloon like Gopi in your lab?
Yes, sir. Yes, sir. We do keep them.
Okay. So in future, 100 atmospheric pressure balloon will be available. Maybe next year or 2 years from now. So this is made of carbon fibers, and this
Okay.
patent has already been submitted. FDA approval is waited. So balloon also can do some wonder, whether it is IVL, high pressure balloon from 45 atmospheric pressure to 100 atmosphere. So you have to prepare the bed, break the calcium, then only long-term outcome of any device, whether it is bioadapters or the drug-coated balloon or stent, is going to be fruitful. Now, if you have an under-prepared bed, always translates into recoil and restenosis. Maybe in future, you have to wait for bioadapters. The mistake you do of not expanding the stent on the spot may be taken care of by bioadapters, which can enlarge in size by 10 to 15% with time. So for the time being, you have to be happy with the existing stent, and post-dilatation is mandatory. Imaging is mandatory. The way you have done is nicely a luxury of treating this calcified lesion, and you had a beautiful outcome. Thank you.
Thank you so much, sir. Thank you so much, sir.
Thank you, doctors, for the comments on the case. Our next presenter for today is Dr. Abhinav Chabra. He will present the case titled Height Slide, Coronaries Died, 2 cases of delayed coronary occlusion after TAVI. Over to you, Dr. Abhinav. Your screen is visible
Good
to
evening.
us.
Am I visible?
Yes, you are visible.
Okay, thank you. Good evening, Dr. Hazra sir, Dr. Reddy sir, and thanks to AstraZeneca and Centimed for this coronary quest. So I will be presenting this case of height slide coronary died. In both cases are delayed coronary occlusion post TAVI. So, just a second. So, as we know, delayed coronary occlusion are rare, unpredictable, and often catastrophic. So traditionally, the only point was the low coronary heights. If it is there, then we have to protect, but can occur even with anatomically safe heights. So these cases, our first one is the delayed left main occlusion post-TAVI, and it was acute hemodynamic compromise and requiring urgent intervention. And second is the right side RC occlusion, subacute presentation, and managed with the PCI. So this was the first case, 80-year-old gentleman having severe aortic stenosis of gradients around 84 by 58. Area was around 0.7. It was a bicuspid anatomy type 0, having a severe aortic calcification. As you can see, it was more on the leaflets. There was LVOT, which almost is equal to the annulus, and you can see the heights. Height was adequate. Left was around 19.3 and right was around 18. And secondly, the sinus of Valsalva was also roomy. And we have measured that right leaflet was around 14 and the left leaflets was around 18 mm. Other parameters were favorable for TAVI. So we have used a 27.5 my valve with 2 cc extra, which was around 8% oversize. And these were the deployment chutes. You can see the valve was deployed well. So this is the valve which is getting deployed, and post deployment, you can see a shift of the calcium towards the left coronary. Patient was okay. There was no hemodynamic compromise. And after 10 minutes, you can see there was a left main occlusion. And it was a shaft occlusion, the mechanical obstruction from outside. You can see the complete calcification, which is moving towards the shaft in both the views. So immediately the left system was crossed with the routine workhorse wires. And the stent was deployed after pre-dilatation. Since after pre-dilatation, after doing the IVUS, we checked there was again some residual stenosis. MLA was not achieved. Then we have used one more stent to give us strength. So it was first was the Zynes and second was the Onyx, a thicker stent. So you can see both the stents, one having a waist around the middle one. So there was 2 stents which were deployed and post-dilated with the 5 balloon. And the final IVUS showed a good MLA. This is the post-coronary shoot. Similar, the second case, it is again a bicuspid anatomy type 1 and an area of around 0.6. There was some calcification, but leaflets were not that much calcified. And coronary heights in this, the left was also, both the coronaries were normal, around 15 and 16. And the roomy sinuses. In this, we have checked all the parameters because we have learned from the left previous case. We have checked left wall to left coronary and right coronary heights and the wall leaflet length as well. In this, we chose 29 mm the Sapien wall, and it was deployed, and we have checked the simultaneous. We have taken the simultaneous shoot. We have protected the coronaries, as you can see in the first image. And both the coronaries were feeling well during the simultaneous shoot. So 45 minutes post-TAVI, patient started having chest discomfort and their STT changes with variable blocks. So 2D echo was done, which showed RV hypokinesia. Immediately fluid resuscitation was done. BP was around 60, patient was in cardiogenic shock. Check angiography revealed that RC having 100% occlusion. There was a trickle of blood, which is evident in the right coronary shoot. Wire was crossed and a chimney stent was done. And the post dilatation was done with 5 balloon. And this is the final shoot. So this was the case, and the key takeaways from this is the coronary height alone is not a coronary risk in TAVI. So we have to check for the leaflet lengths, especially in the bicuspid cases. And delayed coronary occlusion, though rare, can be catastrophic and may occur despite seemingly favorable anatomy. Again, the leaflet length, which can be a decisive determinant applications. In bicuspid valve, bulky leaflets and long leaflets, this may displace towards the coronaries after the valve deployment. So when coronary risk is suspected, we have to always be prepared with coronary wiring, chimney stenting, pre-basilica and leaf modifications. And these procedures should always be monitored, delayed ischemia is in the subacute phase. Thank you.
Thank you, Dr. Abhinav. Experts, your questions and insights.
Nice.
I think
Both are very complex cases, but the first case, the pre-dilatation was not done.
No, the heights were around 18 and 17. So the leaflet length was not 17. So we were like, we are okay. But the sudden compromise was the
usual practice. I think I personally believe in bicuspid valve, especially type 0. Pre-dilatation will be mandated, especially if there is a large calcific chunk from the side where the coronary is coming. For two reasons. One is we have to crack the leaflet. Many times the calcium, of course, won't crack.
Sorry,
and it will
sorry
go
to
up
interrupt you,
towards
sir,
like
but
a trap door.
pre-dilatation was done, but simultaneous shoot was not taken.
Shoot was not taken, yeah. That
Yeah,
trap door
pre-dilatation
will
was
be seen very well. Once you dilate, inject, the second case you did that. The first case
Yes.
definitely would have shown the calcium sitting there in the ostium. And then probably what else can you do? Even then, probably you might have to use a self-expandable valve. Maybe the problem will be lesser with a self-expandable valve. We're not sure. I think the only way is once you notice that in a pre-dilatation shoot, probably you have to go in for a protected system. Put a guide, everything.
But in the first case, it was going towards the shaft. The complete leaflet went into the shaft, not in the ostium. It was not a curtain. It was just hitting towards the shaft of the left main.
Absolutely. Yeah. From below, it was pinching out. It's rare cases. I think only way is if the patient is not a very high risk case for SAVR, surgical would have been the choice. But if risk is high, you have to go in for this. Yeah, good saves. Because the second one also is a very surprisingly a little bit rare, unpredictable in this case. You could not predict it. But then the only way to salvage is like that. Excellent.
Thank you, sir.
I think first case is very, very interesting and unexpected. So there are people, I think stent megatron should be available in your lab. These are the stents where you don't need to put 2 stents because these stents are very robust. The recoil is maximum. And obviously in a calcified aortic valve, you can have calcified ostia and left main. So I just wanted to have your viewpoints. Suppose you put another stent through the aortic valve, a small stent, and push the calcium down since it is not a carton. So take a small guiding catheter and go through the starts, push the stent downward and inflate it, just like side branch stenting through the TAVR. People have done it in the past. And do you like the idea, or it's just a bad idea? You
so you
got my
mean to
point.
say not putting it in the ostium, putting it outside the in the calcium part?
Yeah. So what I'm saying, through the TAVR start, you enter and push the calcium down and put a stent and inflate it so that the distal end of the stent will push the calcium down and will establish the flow. Got my point? Ready?
Yeah, understood, sir.
Sounds good or horrible?
Yeah, it sounds good, but we have to use something covered stent or some bare metal like thick studs like peripheral or something like which can bear that calcium.
The problem is if you develop any kind of hypertension, put double layer of stent, another chance of stent thrombosis it can also kill the patient. No, you have spent so much of money. So it is unexpected, but that's what we do in every day. Like it was completely unexpected. The height was so good. And because of the calcium, it was not a curtain of the leaflet. It was basically boulder. The boulder is sitting in front of the ostia. You have to move away the boulder by somehow putting a stent or by another stent going through the TAVR. But nicely done. If you present this type of case, you are already winning the competitions.
Thank you so much, sir.
Excellent.
Thank you, experts. Thank you, doctor. With this, we proceed with our final presenter for today, She's Dr. Maria Jyoti. She will present the case titled on low contrast PCI elderly patient. Over to you, Dr. Maria.
Yeah, thank you. I'm just trying to share my slide because he has to remove the slide, I suppose.
Right. Dr. Abhinav, we would request you to please stop sharing your screen.
Stop share.
Thank you, Dr. Abhinav. Dr. Maria, yeah, we can see your screen.
Yes. Is it visible?
Yeah, we are able to see your screen.
Yeah. Good evening, everybody. Thank you for the opportunity for the presenting this case. I'll be presenting a patient who's been elderly gentleman, and most of the times, as the advances in the science are happening, we find even the lower people with the 40 to 50 years of age. At the same time, we are finding even octogenarians coming up with the coronary disease and also with aortic stenosis. One such case, inappropriately low rates of angiography are happening in the elderly people, especially with renal insufficiency. So there is a significant decrease in the utilization of the coronary angiography among patients with CKD, possibly a risk of aversion to the risk of contrast-induced nephropathy. One second. So here is my 80-year-old gentleman who is a diabetic and hypertensive, and he's been diagnosed to have ischemic heart disease elsewhere and has been on medical management since a year. And he was denying the procedure. To present with us, he presented through 2 or 3 OPDs to us with symptoms of chest discomfort. Initially, he was denying for the procedure, so we managed him medically. ECG showed sinus rhythm and echo showed moderate LV systolic dysfunction, EF of 35%. Cardiac MRI done elsewhere showed basal viable, and all territories of the L6 and RCA was viable. So because of the unstable angina since past 10 days, he presented to us and he decided to undergo angiogram and revascularization this time. To begin with, the creatinine was 2.17. With the help of the nephrologist, we admitted him. We managed him for a couple of days, and then the creat was 1.57. To begin with, the creatinine clearance was 34 ml per minute. Then we performed the angiogram, which actually showed the RCA being dominant, proximally ectatic, followed by a total occlusion of the entire RCA. It is a thrombotic occlusion, slowly filling vessel. We could also see the LAD being filling distally with the, we can see a retrogradely filling vessel. At the same time, the conus of the RCA also filling, giving collaterals to the LAD. Coming to the LAD vessel, proximally having 70% lesion followed by mid-total occlusion. It was a blunt end. We could see the RCA filling retrogradely. We could also see that the ostial of the diagonal also is diseased. It's around tight 90-95% lesion. So following this, we here have an octogenarian 80-year-old gentleman denying any procedure further. So diabetic hypertensive, CKD patient, near total occlusion of a slow filling vessel, tortuous course of the RCA and CTO of the LAD, double CTO. So we decided to operate first the RCA. At least if we revascularize one of this vessel, it is anyways filling retrogradely. And so when we can think about the left side. So we approached the low contrast PCA with IVIS guidance, and we started with the 7 French JR. Initially, with the JR, it was difficult. We had to go with the another anchoring balloon along the side of the side branch. We dealt it with 2 balloon. Another Xian blue wire tried to cross with. And when we took a microcatheter, we pass the pilot and then we exchange with the cyan blue wire. So following dilatation with 1.5 mm dilatation of the balloon, we ran an IVUS. For a surprise, it was understandable because there was mixed amount of calcium and fibrotic lesion. From 12 to 6 o'clock, we see fibrous. This is from the distal to the proximal segment of it. And as we go on, so this, even it is opening into the RCA, little roomy, but as we go towards the proximal part where the wire is coming, the side branch, there also the artery is narrowed. So the area was quite, entire RCA is quite diseased. So we did a serial dilatation initially to begin with 1.5, slowly with 2 mm balloon. And there was certain area where it was very difficult to open up. These are the two areas. So we had to use OPNC balloon. With the help of the OPNC balloon, it is very easy to go up to high pressure atmosphere up to 35 and then crack this because of the amount of the calcium being there, or it is not opening up. At the same time, we also had to use the cutting balloon in this areas in the mid RCA because there was a 360, almost was a quite fibrous plaque being present. We also measured through the IVUS. The length was around 48 mm. This is the cuts what we can see with the help of the cutting balloon as we go through here. And then following that, we were able to measure the pre-IVUS measurements after this pre-stenting measurement, the proximal area, and as well as the distal area, the reference luminal area, which was less than 50% of the plaque burden. It was around 4.49 and 4.56, and distal was 3.61 into 3.51. We could see that 180-degree of the calcium arc being present, which we tackled with the OPNC balloon as well as the cutting balloon. After this, with our reference vessel, which was already there, the wire being there, we removed the balloon there. And then we deployed 3 into 48 mm drug eluting stent, followed by we post-dilated with 4 into 12 mm and 3.25 distally. Following this, we ran an IVUS. Distally, it is expanded well. There is no malapposition, there is no edge dissection, but proximally we could see there was malapposed because they are more prone for stent thrombosis. So it was not well opposed. We again went with a higher atmospheric balloon of 4.5 into 6. This is the end result what we achieved. The only here the dye we have used at the end. We have never used dye in between. This is the end result. Following that, we were a little bold. We thought we will also try to address the left side of the vessel because the patient was stable. So we started going with a Shion blue wire, 6 French 3.5 mm, and then we tried drilling across the microcatheter. The LED was a blunt and it was tough to go through, so we went across the diagonal wire. So here also we could, for a surprise, we ran an IVUS to know that there was 360-degree calcium, which we could see here, which is superficial calcium. It is very tough to crack with. It was just at the beginning, as we see here, just at the opening of the LED, it's been there. So again, we had to use an OPNC balloon of 2 into 10 mm, then IVUS cutting balloon at that center. And then following that by, nice result we got. And then we pre-dilated the LED with 3 into 10 mm balloon and dilated well. After that, we deployed, this is the post cutting where you can see some cuts here. See, seen here. And then this vessel has been opened up well now after all this cutting and the opening OPNC balloon. Following this, we deployed 4 into 12 mm drug eluting stent in the proximal of the osteoproximal LED, pre-dilated even the LED with 3 into 10 mm balloon. Then following that, we did a pot of the 4.5 into 6 in the proximal part, and then DB to the D1, that is 2.25 into 20 mm. In this vessel, when the vessel is good, better to do a drug eluting balloon, the side branch, so it will be easier. Following that, post-stenting, we ran an IVUS. Here we have never used the dye again. We could see that there was an under expansion in the osteoproximal part. So because of which it is not touching, you can see some blood here. That's the reason we again went with the 5 into 6 mm balloon. After doing this, this is the end result what we have got. So both the LED and it's flowing well, the diagonal part. And then the patient was stable throughout. This is the RCA what we have got. Patient has been followed with us is more than a year. Luckily, his creatinine is maintaining with 1.6 mm. It's not gone high. EF also has improved to 40-45%. He's doing good. Multiple trials now.
Just 1 minute remaining. Sorry to interrupt. You have 1 minute
Thank
remaining.
you. Thank you. As we know that IVIS and OCT, image-guided PCS has, especially in the complex PCS, has been already in the guidelines. It's the class 1 indication. So multiple studies, including the ultimate trial study, the follow-up of the study shows that when we use these images, we prevent stent thrombosis, we prevent target vessel failure. So we could see that there was very good expansion in our vessel. Another important thing is whenever low contrast PCA is considered, it is to start with beginning. First is a proper hydration, considering the limiting the OHAs and other drugs. Stop those nephrotoxic drugs a day or 48 hours prior. Take a time to discuss with the other specialties. Then get the old angios or CDs or echoes. Get a dynamic roadmap and zoom out. Avoid panning, especially in the radials, avoid spasm. If required, take a ultrasound guided punctures. And of course, we have multiple other modalities which is also available. Still, some are still not available in India, but only use the best of them. So conclusion, PCA has relied on contrast vessel opacification since its inception. Ultra low contrast PCI can improve both safety and quality of complex intervention. Many complex PCI subgroups can benefit from this in addition to the patient with CKD. And CKD patients have worse outcomes. They have increased risk of cardiovascular disease, less likely to receive treatment. These patients should not be denied the need of revascularization. Thank you, sir. Thank you.
Thank you, Dr. Maria. Experts, stage is yours for question and comments.
Nice, Dr. Maria. It's both vessels. This is the cases, of course. You have to use IVUS. There is no alternative. You want to reduce the contrast. No rule for OCT. So well done. Both were done, I think, with minimum dye. And in cases where it is feasible, not so difficult calcium lesions, you can sometimes using a 5 French guide, possibly in elderly with simple lesions and ACS settings is also helpful to reduce the dye. A well done case.
Thank you,
Hazra?
sir.
Yeah, nicely done. But what was the ejection fraction in this patient?
To begin with, it was 35%, sir.
And on follow-up?
Follow-up, it is 45%.
Wow. So one is flow, second is improvement in the ejection fractions and quality of life. We're not expected to increase the death rate, I would say, in these group of people, but definitely the anginal burden is going to come down. So maybe in future, we will have coronary sinus reducers for those people who are having triple vessel disease, severe angina, undoable case, CKDs. So there are thoughts on this type of bad patient, I would say. Whatever you do in this patient, there is high chance of stent thrombosis, the creatinine can go down, creatinine can go up, GFR can go down. Ejection fractions may not improve. The BCIS trial recently has said that perhaps a medical therapy is as good as doing angioplasty, even with MCS. So this field is still open, but in India, I would have done the same way as you have done. So at least should be given a chance, as you have said, that right to live without any angina is a democratic choice of people. Now, for some people, it may not be that scientific way to live, but it's a more democratic way. It's his choice. So this consenting is very important. Patients counseling is very important. The drug modifications after angioplasty is important. The LDL lowering drug is very important along with your beautiful angioplasty. Thank you. Nicely
Thank
done.
you, sir.
Thank you.
Thank you so much, sir. Thank you, sir.
Thank you, Dr. Maria. Thank you, experts, for your insightful comments. And that brings us to the end of the presentation for the India Coronary Conquest 2026. A heartfelt thank to all our course principals, Professor Dr. Kamal Sharma, Dr. Prakash Kumar Hazra, and Dr. Y. Vijay Chandra Reddy. Thank you to all presenters as well for those excellent and insightful case presentations. We will be reserving the result as of now. This course will be compiled across both course principals, and the final result will be shared with the participants over the email. A very humble request to both our course principals, Dr. Prakash Kumar Hasra and Dr. Y. Vijaychandra Reddy, to please share the score sheets with us by today itself. It will be extremely helpful in making arrangements for the upcoming sessions. The AstraZeneca representative will be in touch for further updates regarding the results and the next steps. Thank you once again to both the course principals
Akansha,
and the
one second.
presenters.
Where are
Yes,
the
yes.
scorecards, score sheets are there? I couldn't see.
Yes, yes.
So, so it's in your mail, sir.
Okay, okay. I'll go through that. Yeah.
We have attached those sheets, so we
Okay.
request you to fill those and share with us
Yeah.
today only.
Okay.
And yes, we look forward to seeing you in our next sessions. Thank you and very good night.
Isaac,
Thank you.
is
Good
there
night.
any bonus marks,
Thank you, sir.
bonus point from the organizer?
I'll check that, sir, and we'll keep you posted.
Thank you,
Okay.
sir.
Thank you.
Bye-bye.
Thank you.